Hi, Dr. Karthik.
Hello, sir. Good evening, sir.
Good evening. By the time everyone is joining, can you once start the PPT? We can see if it's running normally or not.
Okay,
Only
sir.
the
Now,
opening slide.
okay, sir. I'm sharing, sir. Is it visible, sir?
Yes, it's working. Can you play the slideshow?
Yes, sir. Is it okay, sir?
Yes, it's working.
Okay, sir. It's moving also. Okay, sir.
You can close it now.
Stop sharing this. Okay, sir.
Hello, Shashank. Good evening.
Good evening, sir.
I think many members have already joined this meeting. Hello, Karthik.
Hello, sir. Good evening, sir.
Good
Right now,
evening.
10 participants are there, sir.
Okay.
Let us wait for Siddharth, sir, and Gautam Das, sir, if they will be
Gautam
joining.
sir actually, I think, has joined.
Yes, I have joined. I am
Yes.
already joined.
Yeah. Good evening,
Good
sir.
evening, sir.
Manish from KGMU, sir.
Yes, good evening. Good evening.
Good
How
evening,
are
sir.
you,
Good
sir?
evening.
Yes, I'm fine.
So how is the weather there, sir?
Yes, it's nice.
Okay, sir.
Not that
Now
hot.
here it is drizzling.
Yes.
Aha.
Here, yesterday there was some rain and
Okay.
weather is pleasant.
Okay, sir. So we will start our this webinar in within next minute. Let
Yes,
Siddharth
yes.
join.
We will start at 6:30, sir.
Yeah. And duration is of 1 hour.
Yes, including the discussion part, sir.
Okay. Okay. So I welcome on behalf of Pain Edu series to all the participants, all the viewers. I welcome Dr. Karthik, who is pursuing his DM from AIMS Rishikesh. He is the speaker. As chairperson, I welcome Dr. Gautam Das. Uh, need no mention about sir. Al- And I also welcome Dr. Siddharth. Siddharth, are you there? I think Siddharth is not there. He is guest faculty. He will be adding points to our discussion. And I also welcome Dr. Sarita Singh and Dr. Ajit Singh. Ma'am is president of the our society, and Ajit sir is secretary. So, with permission of chairperson, can we start our discussion, sir?
Yes, yes, you can go ahead.
So it is all about uh, cranial neuralgias. So it will be a case-based approach to a patient of cluster headache, and in which we will discuss something about trigeminal autonomic cephalgias, and then we will finally focus on the cluster headache, management of the cluster headache. So Karthik, it's your session. You are welcome to start your session.
Yes, sir. Thank you, sir. I'm sharing the slides, sir.
Yes, your slides are visible.
So,
You
Yes.
can go ahead.
so it's not moving. Previous.
Not moving.
Yes, sir.
Okay.
Yes, sir. Good evening, everyone. At the outset, I am thankful for the organizing team for giving me this opportunity. Special thanks to Dr. Sarita ma'am. So today, so is it audible, sir?
Yes, yes, you are perfectly audible.
Okay, sir. So today I will be discussing about the practical and structured approach of cluster headache. Here I will be focusing more on the diagnostic criteria and pathophysiology and stepwise management part. So coming to the cluster headache, we know it is one of the most painful condition we encounter in the pain clinic. Cluster headache is one of the primary headache belonging to the group of trigeminal autonomic cephalgia. The other headache in this group are paroxysmal hemicrania, sanct suna, and hemicrania continua. The important or cardinal clinical feature here is the presence of unilateral trigeminal pain as well as associated with ipsilateral autonomic symptoms. So let me share a clinical case vignette. We got a patient who is 30-year aged female healthcare worker. She came with a history of severe right side orbital as well as periocular pain with a severe intensity of NRS around 8 to 10. And she had the clusters every once or twice a year with each clusters last about
That is
1
what
to
you are there for
1.5
ना
months.
Hello.
Mangesh is there everybody was informed इनको मैं देखता हूँ जो
Yeah. And in
हाँ
each
तो
month,
Well, hello, hello. I
व्हाट डजंट
welcome.
कम बिफोर टाइम मेरा तो केसेस रहते हैं ना उससे जो एक
Uh,
एक करके जो होता है
no
रोलिंग
problems, no problems. Hi, welcome, Siddharth.
हाय सर
We are in the we are started. We have already started this discussion. Only first slide is there. So please
Yes,
join.
sir.
Please join.
Yes, sir. Yes,
Okay.
sir.
Okay.
Yes, sir. Again, about the clinical case. So we had that 30-year-old female healthcare worker who came with a history of severe right side orbital pain and around bouts of 1 to 2 bouts per year, and each bout lasts around 1.5 month. And in each bout, she had the episode of 1 to 3 episodes per day, her headaches, and each episode which last around 30 to 45 minutes of duration. Coming to the other associated feature, she also had the history of unilateral right side lacrimation and conjunctival injection as well as rhinorrhea. And she gave the typical history of waking after about 2 hours of sleep because of severe pain. And about the behavior, she told she will become restlessness and agitated at the time of attacks. And last feature is she will be completely pain free in between the 2 episodes. So coming to the diagnosis part, we found the key clinical features like ipsilateral involvement, the location of the pain, it's over the orbital and supraorbital region, and the intensity was severe, around NRS of 8 to 10. And the most important factor is her behavior, the future of restlessness. It's different from migraine patient. So about the cluster pattern, she was completely pain free between the two cluster periods. Like each cluster last around 1 to 1.5 month, and the cluster pain free period is more than 3 months. So it indicates episodic bouts. Also, she has given the history of waking from the sleep after about 2 hours. So it indicates the circadian pattern, the involvement of the hypothalamus. At the same time, her attacks happen in the same months every year. It indicates about the circannual recurrence. These are the important features, the periodicity in the cluster headache. Coming to the gender pitfall, we usually think the cluster headache has male preponderance. So physician commonly miss the diagnosis in the woman. They might think it as a migraine. So brief about ICST 3 criteria. There are 5 criteria, and the first one is it should have more than 5 attacks, and the duration of pain would be around 15 to 180 minutes duration, and the location should be around the orbital and the temple region, and they should have the presence of more than one autonomic signs or history of restlessness. About the frequency, the cluster they have one attacks every alternate day to 8 per day. Coming to our case, when we apply this criteria, we got our patient fulfill all the criteria like the duration, the frequency of attack, and the presence of autonomic symptoms like lacrimation, rhinorrhea, and conjunctival injection also. And typically, she gave the history of restlessness. So also we need to classify further it as a episodic or chronic type. In episodic cluster headache, the each attack would be last around 7 days to 1 year, and they will have the pain-free remission period about at least for 3 months. And in case of chronic headache, there would not be a remission. Otherwise, they will have the remission less than 3 months. So applying this to our case, our patient had the bout of 1 to 1.5 months, once or twice a year, and completely pain relief in between the two bouts. So here it meets this episodic cluster headache criteria. So our final diagnosis was episodic cluster headache, the code ICST 3.1.1. Coming to the other differential diagnosis, we should differentiate from the trigeminal neuralgia also. Here, the trigeminal neuralgia would have electric shock like pain. Our patient has stabbing type of pain, and the triggering factor would be present in case of trigeminal neuralgia, like touch, chewing the cold air, and face washing would trigger the trigeminal neuralgia. And in trigeminal neuralgia, they would have the they don't have the autonomic symptoms and signs also. And one more important DD is migraine. Here, the restlessness is a key factor here. The clusteretic patients tends to move at the time of attack, like they used to pace outside the room, and they would be restless and agitated. Whereas the migraine patient prefers to lie still, especially in the dark, quiet room. Coming to the isolation of other trigeminal autonomic cephalalgias from the cluster headache. Here, the important clues are the duration of the pain as well as the response to indomethacin therapy. So, in paroxysmal hemicrania and hemicrania continua, these patients are especially have a traumatical response to the indomethacin therapy. And also by comparing the duration, the cluster attack patient have longest duration 15 to 180 minutes, the shunt have shortest duration 1 to 600 second only,
दादा
whereas
पौर्णश्री जाने का रास्ता पौर्णश्री
hemicrania continua
सो
have
जा
the continuous pain
सीधा सीधा जाएंगे
with fluctuation of fluctuating exacerbation.
अंदर से कोई पुल के नीचे से रास्ता
Shashank,
Please,
था ना
mute, mute, mute all of them, Shashank.
okay.
Please continue.
Then
Please
about
continue.
yes, sir. Then about the red flags, it should be important to rule out the red flags because some pituitary tumors or other vascular malformation can present similar to the trigeminal autonomic cephalalgias. So we can use this mnemonic to rule out the secondary causes. If we find any atypical features or symptoms, we should go for further evaluation with the imaging. Then coming to the pathophysiology, the understanding the pathophysiology is very important to decide the treatment part. The core clinical pathology here is the involvement of a triad. This the interaction between three structures like a hypothalamus. We know it is a circadian generator, and the involvement of trigeminal cervical as well as vascular system, and finally the involvement of parasympathetic system through the spinopalatal ganglion. So about the hypothalamus, we know it's a biological clock. It is a circadian generator. This is responsible for the alarm clock type of pain. The patients will have the pain during same month as well as same time every day. So the hypothalamus is involved here. Then about the involvement of trigeminal vascular system. The trigeminal nucleus caudalis is present in the brainstem here. It is the central relay over here. When the hypothalamus gives the trigger to the trigeminal nucleus, it will cause the pain to transmit through trigeminal nerve, especially the V1 division. So the activation of the V1 will cause the trigeminal pain. Further, the CGRP will get released here. It will cause cerebral vasodilatation and all. We'll be seeing in further slides. Also, the important point is the involvement of or convergence of trigeminal system with the cervical part, especially the upper cervical C1, C2, C3 component. We know the dorsal part of the C1, C2, C3 will converge near to the trigeminal convergence in the brainstem. So this is the factor we can modulate the pain by giving the Gone block also here. Then about the autonomic reflexes. So the trigger stop from the posterior hypothalamus. It will activate the trigeminal afferents V1 pain. This will cause the trigeminal pain over the orbit, supraorbital region as well as temple region. At the same time, this activation of the trigeminal afferents will activate the superior salivary nucleus in the brainstem. That will cause the parasympathetic activation, and the final relay would be the sphenopalatine ganglion. That will cause the autonomic symptoms like lacrimation, rhinorrhea, etc. Then brief about sphenopalatine ganglion. We know it is the final parasympathetic relay point responsible for lacrimation and congestion. When we go deep into this anatomical as well as pathological pathway, uh, these parasympathetic preganglionic fibers will come from superior salivary nucleus that will pass through the facial nerve here. Then it relay via the greater petrosal nerve. And interestingly here, the greater petrosal nerve will join with the deep petrosal nerve to form the Vidian nerve or nerve of Derricoid canal. So the preganglionic parasympathetic fibers coming here and snaps in the sphenopalatine ganglion. After that, the postganglionic fibers will go along with the maxillary nerve. Then it will supply the lacrimal as well as nasal glands. It is the reason for lacrimation as well as rhinorrhea in cluster headache patients. And the sympathetic fibers also coming through internal carotid flexus through the T petrosal nerve. It will join here sphenopalatine ganglion, but it will not snaps here because it is a postganglionic sympathetic fibers. Now about peripheral mechanism, the involvement of neuropeptides. The most important neuropeptides released will be the CGRP, calcitonin gene related peptide. It's a potent vasodilator, main mechanism of cluster headache. And other neuropeptides like vasoactive intestinal peptides, substance P is a pro-inflammatory mediator. And one more is PACAP38. This is pituitary adenylate cyclase activating polypeptide. These are all will be increased, the levels will be increased. Then about the CGRP, when there's activation of the parasympathetic activity will release the CGRP, especially in the external jugular venous pressure and internal carotid artery. These will cause profound vasodilatation as well as neurogenic perivascular inflammation will happen. When it happens, these edema will compromise the carotid canal and could cause the neuropraxic injury to sympathetic fiber also. So it is the reason for ptosis and meiosis in the cluster headache. There will be the local activation of sympathetic dysfunction also. Then about the role of central sensitization. Due to the repeated stimulus from the hypothalamus, some patient will develop from episodic to chronic cluster headache. When the central sensitization happens, these patients will have a poor response for any therapy. Coming to the management part, we usually follow the four-step treatment algorithm. It starts from pharmacotherapy, that is acute treatment, transitional or bridge therapy, then preventive therapy as well as interventional role. When we speak about investigation, actually cluster headache is the clinical diagnosis. We don't need investigation to confirm the diagnosis, but it is needed to exclude the secondary causes. Also, it will provide the reassurance for the patient and attendant as well as for the doctors. Especially, we should do the contrast enhanced MRI in case of any atypical features, atypical symptoms. About the headache diary, International Headache Society strongly recommend the use of headache diary. It will improve the diagnostic accuracy also, and it would be helpful to track the pattern of headache. And some patients will not be able to recall their symptoms. So in these cases, it will be very much useful. Coming to the first non-pharmacological and behavioral management, the core advice should be the patient education. First, we need to educate the patient about their disease, and we have to sensitize the patient about the possible triggers for cluster headache, like alcohol and high altitude are the possible triggers. Then comes the sleep and the lifestyle modification. We should advise them to maintain a regular sleep wake cycle, and our patient is also staff nurse, so we advised her not to take part in the shift work. So the patient should avoid the shift work, and sleep disruption should be avoided. So coming to the management proper, the four-step approach, the acute treatment is for aborting the acute attack, and the transitional therapy is one bridge between the acute and preventive therapy. Then comes the role of interventional part. First step, acute or abortive treatment. We know the cluster headache has a rapid onset of the pain, as well as it will peaks, the pain will peaks very rapidly. So we need faster acting therapies, ultra short acting therapies should be given, like oxygen and subcutaneous sumatriptan and all. First about high flow oxygen therapy. High flow oxygen about 12 to 15 liter per minute with 100% oxygen should be given for 15 to 20 minutes with sitting, and we have to use non-rebreather mask also for achieving the higher concentration. Then role of triptans is gold standard therapy. One more gold standard therapy. We have to give subcutaneous sumatriptan. The dosage should be around 4 to 6 mg. Nasal alternatives can be used, but the onset will be delayed. And recently, the role of non-invasive vagal nerve stimulation also came into the play, and it is also a US FDA approved, especially useful for episodic cluster headache. And this non-invasive option is can be useful for both abortive treatment as well as preventive treatment also. Coming to the step 2 is the transitional therapy. Here it is useful to rapidly suppress the short-term cycle suppression, and here it will act as a bridge between the acute abortive treatment and preventive therapy, because the preventive medication will take time to act. In the meantime, it will be helpful, transitional therapy. There are so many options like usage of corticosteroid. Corticosteroids like oral prednisolone can be used 1 mg per kg over 3 to 5 days. After that, we have to taper it over 2 to 3 weeks. And we should be cautious in patients like diabetes mellitus and all. And here the gone block. Here the pain vision role comes into the play. The simple gone block with local anesthetic and steroid can break the cluster cycle. We could block the greater occipital nerve distally at the level of occipital protuberance or at the level of C2 spinous process. Like with the usage of ultrasound guidance, we can block here also, like in between inferior oblique capitis muscle and semispinalis capitis. In this plane, we can do. And for our patient also, we have given the gone block. Then comes to the third step, the preventive pharmacotherapy. Here, the most practical or important point is we should initiate the preventive pharmacotherapy along with the abortive and the transitional therapy itself. That will reduce the frequency as well as intensity of the pain. Try to say it's not move. Okay. First about verapamil. Verapamil is the first line therapy for prevention. The oral verapamil about 80 mg TAD can be started and it could be titrated even up to 960 mg per day. But we should be cautious while using the verapamil. The ECG is mandatory, baseline ECG should be done. And when we increase the dosage more than 240 mg, we have to do the serial ECG every for 10 days after increasing the dose. Because the verapamil has the risk of causing PR prolongation that could lead to the bradycardia as well as heart block. Others less important side effects like leg swelling, constipation, and gingival hyperplasia also would happen with the verapamil therapy. Then comes the role of lithium. Lithium is especially useful in chronic cluster headache in the dose of 300 to 900 mg per day. But the rigorous monitoring of serum levels of lithium should be done. We should not allow the lithium to rise above 1.2 milliequivalents per liter. Otherwise, it would cause a neurotoxicity and all. At the same time, we need to monitor renal as well as thyroid function also because it has the propensity to cause goiter, diabetes insipidus also. So we could use lithium along with the verapamil combination therapy. Other alternatives like dopyramate could be used. Around the dosage would be around 100 to 400 mg per day. And the melatonin is very safest and good efficacy would be there. We could use night dose 9 to 10 mg. It will be useful to maintain the circadian rhythm. It will act on hypothalamus. We know it's secreted from pineal gland. And one more important targeted therapy option is calcanisumab. We know it's the emerging CGRP monoclonal antibody. And a brief about CGRP. CGRP antibodies. CGRP is elevated during the cluster headache. That will be the cause for vasodilatation as well as neurogenic inflammation. So if we give the calcanisumab, it will go and bind with the CGRP and will prevent their action so that the vasoconstriction would happen and it will prevent the neurogenic inflammation also. Also, it is recently getting got the approval by FDA, especially for episodic cluster headache. The dose would be around 300 mg subcutaneous monthly during the active cluster periods. Side effects like injection site pain, constipation, and vertigo can occur. The limitation, like it is very expensive. More than even 120 mg would be around 50,000 each injection. We need three injection, 300 mg, and also it is not effective in chronic cluster headache. Coming to the intervention part, here the pain efficient role is very important. When do we intervene for the patient? If the patient have chronic cluster headache and refractory to the pharmacological treatment, we should go for intervention. Other indications like frequent episodic attacks, even with optimal pharmacotherapy, and sometimes the patient will have contradiction for usage of preventive therapies like verapamil and lithium, the cardiovascular patient, and sometimes we can use the intervention as bridge therapy also, like simple gone block or sphenopalatine ganglion block, nasal therapy, nasal approach. So what are the anatomical target for the intervention available here? The first one is sphenopalatine ganglia. It is a main autonomic relay or final parasympathetic relay point. Then peripheral greater occipital nerve block. Then central pacemaker, that is a hypothalamus. Then about the interventional ladder, we should not go for a very invasive therapy initially. We should move from simple therapy like con block, SPG block. If they are refractory to these intervention, then go for RFA and neurostimulations. Sphenopalatine ganglion block. It is highly effective as a abortive therapy as well as useful for transitional therapy also. Normally we use this infrazygomatic approach, fluoroscopy guided as well as ultrasound guided could be useful. What is the mechanistic rationale here is when we block the sphenopalatine ganglion, it will halt the hyperactive parasympathetic efferent loop. So the vasodilatation part would be taken care of. Also, the subsequently it will stop the neurogenic inflammation to activate the trigeminal pain. And the AP view, the target would be the end point would be lateral to the nasal wall. The tip of the cannula should lie lateral to the nasal wall. Needle passed below the zygomatic arch towards the pterygopalatine fossa. And that about the transnational SPG block. Here we could use the cotton tipped applicator, should be soaked in the local anesthetic agent, and it is a simple OPD technique to quickly abort an acute attack. Then about the role of RFA. When the patient is refractory and have intractable pain, then we should go for radiofrequency ablation of SPG. This would provide long-term relief for that patient. And sensory and motor stimulation should be done. We should avoid injuring the maxillary nerve. When the paresthesia is present at the time of stimulation in the upper teeth, it means the needle is superior lateral, so it should be redirected downwards and medially. Then about the neuromodulation, the usage of SPG stimulation. This one is surgical approach. Here we could implant the microstimulator near the SPG ganglion in the pterygopalatine fossa, and the remote controller can be used to deliver on-demand high-frequency stimulation to instantly abort the attack. Then about occipital nerve stimulation. Here we usually place the subcutaneous leads over the occipital nerve territory, and the IPG will be placed inside the body only. It will provide continuous neuromodulation of trigeminal cervical complex. It is used for end-stage intractable chronic cluster headache. Then about the role of deep brain stimulation. It is strictly reserved for medically intractable refractory chronic cluster headache. The rationale here is we know the hypothalamus is the trigger part or a central pacemaker. So by placing the electrical stimulator over the hypothalamus, we could modulate this pathway. Then finally about clinical algorithm. So the first step is diagnosis. We should rule out the other secondary causes and other red flags. Then we go for abortive treatment like acute usage of oxygen and sumatriptan. Then the step two, we should start bridge therapy like steroids or a gone block. At the same time, we need to start preventive therapy also, like verapamil, galcanezumab, and lithium, topiramate, etc. If the patient is refractory to all these pharmacological treatment, then we need to go for intervention like sphenopalatine ganglion block or RFA, and finally stimulations like occipital nerve stimulation and deep brain stimulation. In our headache, our approach is usually we start all treatment at the day one itself, like acute bridge therapy and preventive therapy, and we should not delay the intervention for these patients. Then coming to guidelines, IASP is strongly recommending the usage of high flow oxygen and subcutaneous triptan, and they are giving the conditional recommendation for sphenopalatine ganglion as well as con block. NICE guidelines says we should offer 100% oxygen and tryptan, and they are telling about the role of verapamil also with the ECG as a first line therapy. And European Federation of Neurological Society guidelines recommending verapamil and also lithium for a chronic cluster headache, and they also suggest corn block as a bridge therapy. Coming to the case resolution, in our case, by combining the treatment like high flow oxygen and corn block with preventive therapy of verapamil, we successfully shut down her bout within 3 days. So these patients should require a team approach. Here we should rely on neurologists and psychologists as well as to holistically manage these patients. It's a take-home message here. The oxygen is life-saving here, and verapamil is the first-line therapy, and the GON block and other interventions like spinopalatin ganglion block are the game changers here, and we should avoid usage of opioids. Thank you.
Thank you, Karthik. Now, forum is open for discussion.
Yes, sir.
Yes, Karthik, it was very nice presentation and almost you have covered everything, almost everything nicely. So
Thank you.
one thing in the stimulation, another thing I mentioned in literature, though we very, and this is basically something like contradictory that we commonly do in our pain clinics. Most of us do the spinopalatin ganglion block, but there are some literature which is telling spinopalatin now neurostimulations can also be effective, which may be looking something the contradictory, but there are few the case reports are there where they have
Yes, sir.
used the spinopalatin the neurostimulation rather
Yes,
than
sir.
block.
Yes, sir. The stimulation part, sir, if you give a low frequency stimulation means it will start the attack, sir.
Right,
So
right.
for therapy, we need to give high frequency stimulation.
Okay, excellent presentation, Karthik.
Okay,
Everything was covered
Karthik.
very
Thank you, sir.
nicely.
Because this cluster headache is associated with circadian rhythm, so melatonin have any role?
Yes, sir. Melatonin I have included in the adjunct, sir. In the preventive
Okay.
therapy, we could use around 10 mg in the night, sir. It
So
will
what
decrease the
about
frequency.
alcohol intake?
Alcohol intake will trigger the cluster headache, sir, especially because
Oh,
of the alcohol can cause vasodilatation and all. So
okay,
we should
but
tell them to avoid.
cluster attacks, alcohol to be avoided.
Yes, sir. To be avoided, sir. Should be avoided.
Yeah, yeah, yeah. Siddharth, hello,
Yes, sir.
hello, Siddharth, are you there?
Yes, sir. I'm here.
Please add.
No, I think it's a very comprehensive this thing. But I agree with him that we start the initial all treatments together. Only thing is, I would do a diagnostic SPG before, and that is if it is not positive, then usually I won't go ahead. So that is, I think, other than that, it was very comprehensive as sir has mentioned.
One about this RF, whether pulse RF, conventional RF to be. Hello, Karthik.
Hello, sir. I could not hear you, sir.
Uh, in stimulating this sphenoparatine ganglion, whether
Yes,
pulse
sir.
RF or conventional RF, they conventional RF.
Sir, your voice are interrupted, sir.
Now, regarding this sphenoparatine ganglion stimulation and RF,
Yes, sir.
So your voice is breaking, so it's not audible clearly.
okay. Uh, hello.
Yes, sir. No audible, sir.
Uh, regarding pulse RF and conventional RF, which is better and is there evidence for sphenoparatine?
Sir, evidence is I have seen on conventional RFA only, sir. And we should avoid damaging the maxillary nerve, sir.
Okay, Karthik,
Yes, sir.
I want to mention one thing because
Yes.
this was very important queries for me also earlier. That what we have discussed very nicely, that the pathophysiology is parasympathetic stimulation, right? So
Yes,
the
sir.
autonomic symptoms what we get is your lacrimation, nasal congestions. These are all related to the parasympathetic stimulation. But few other features of the autonomic symptoms is your ptosis, the meiosis. So these are basically we see, and the conjunctival congestion is seen also in the Horner syndrome. So when we do the stellate ganglion block, so we do the similar kind of symptoms. So my doubts and queries was how and what is related. Is it a sympathetic blocking effect or it is a parasympathetic stimulation effect? So the thing is that when there is a parasympathetic stimulation, it will be like a parasympathetic and sympathetic because it is an the opposite in direction. So when there is parasympathetic stimulation, so there will be apparent sympathetic blocks as well. Means the ptosis, the meiosis, these are because of the dual things, means sympathetic blockade as well as the parasympathetic stimulation. So when there is parasympathetic stimulation, there will be like a apparent the sympathetic blockade effect as well. So we should not be confusing these autonomic symptoms as a Horner syndromes. So basically it's not Horner syndromes, but some features mimics Horner syndrome, like in the ptosis, meiosis
Meiosis.
and the conjunctival congestions, it mimics the Horner syndrome.
Yes, sir. Here, one theory they are telling, sir, because of parasympathetic involvement, it will cause a neurogenic inflammation and vasodilatation of internal carotid artery also. And surrounding the internal carotid artery, sympathetic plexus are present. That sympathetic plexus arise from superior cervical ganglion. So they that edema will cause neuropraxic injury to sympathetic plexus. So it's causing sympathetic dysfunction like that.
That
They are
is good. That is what
recommending,
I'm
sir.
telling. There is sympathetic blocking effect, but that sympathetic blocking effect, there are hypotheses, lot of hypotheses.
Yes,
So
sir.
the what you told, that is one hypothesis. So same way, the other ways is your
Apparent.
when the sympathetic and parasympathetic is opposite. So when there will be profound parasympathetic stimulation, there will be relative sympathetic blockade as well.
Yes, sir. Thank you, sir.
Okay, if any more questions in the chat box, peripheral neurostimulations techniques available in India. I'm not aware whether this is available in India. If anybody knows whether it is available, same way the CGRP antagonist, CGRP monoclonal antibodies, whether it is available in India, that also I'm not aware whether these are really available or not. I have not used.
Sir, in India market, it's showing it's around 45,000 each injection, so 120 mg.
But I don't know
Yes,
whether, because
sir.
no pharma companies yet came and I am not really aware any pharma company is selling it. I don't
Yes,
know. It can be imported. That is the
yes,
definitely, it is available in the US market. That is the definitely is thing. But if any companies are marketing it in India, I am not aware.
yes. And the vagal stimulation is available, sir. Yes. Like
Okay.
peripheral devices placed over the neck.
Right.
Yes, sir.
But sometimes it can be present, cluster headache can be present without autonomic symptoms also. Although it has been classified in trigeminal autonomic cephalgias. I'm Manish. I'm from logging from another account. So this is a feature of cluster can. Cluster can be present without autonomic symptoms also.
Yes, sir.
Sir, how
That's it.
effective is the peripheral vagal stimulator devices? The central the other invasive stimulators, they are giving 50% efficacy, no? The peripheral stimulators, how much is the efficacy and what is the cost?
Evidence I have seen in one article, they are telling 30 to 40% only effective. That too in 40% of the people only.
Thank you.
Yeah. Yes, ma'am.
Okay, thank you. If there is no more question, can we conclude the sessions? What are the
Sir,
organizers?
sorry, I just missed Dr. Karthik's last statement in which he said that probably it is available in India. Can you just repeat it? Is it available in India?
Yes, ma'am. It's available, ma'am. In Amazon and all, it's available, ma'am. Vagal nerve stimulation.
No,
Large.
that is a that is a sort of cutaneous machine available.
Yes, ma'am.
No,
Yeah,
no, no.
yeah.
I was talking about the.
Implantable
Oh,
peripheral.
Yeah.
Yes.
No, I don't. I'm not aware, ma'am. It's
Yeah.
available.
Those cutaneous ones are available. Yes, thanks.
Yes,
Yeah,
yes.
yeah.
So, Karthik, thank you for this nice presentation and queries. I would like
Thank
to
you, sir.
thank all the audience and our chairperson, Dr. Gautam Das sir, our guest faculty, Siddharth Verma sir, our president, Dr. Sarita ma'am, and our secretary, Dr. Ajit Singh sir. Thank you for this wonderful educational evening. Thank you, sir. Thanks a lot.
Thank you, sir. Thank you very much for the opportunity.
Thank you all, and thank you, Karthik, for very nice presentation. Thank you,
Thank you, sir.
Karthik.
Great. Thank you,
Okay, good
everyone.
night.